What's up, everybody? Good evening. Thank you all for accommodating some personal schedule change to make it to where it's starts an hour later. But again, as y'all can see, this is just a CPR overview. It's not that much. There's only 68 slides to go over this evening, so it's not going to be super long anyway. So we potentially be out of here in a little over an hour. Anybody got any questions so far? Recap anything? Do we need to talk about anything that's pressing right now? All right, we'll dive off into this. We'll get it going. So we'll talk about shock and resuscitation. This is stuff that I have to read over and we make sure everybody knows. So it's the fun parts. Shock and resuscitation applies the fundamental knowledge of causes, pathophysiology, and management of shock, respiratory failure and arrest, cardiac failure or arrest, and post-resuscitation management. We'll go over the principles of basic life support. Oh, users. They don't even give me time off into the slides and I start yawning. Since then, the specifics, techniques have been reviewed and revised, obviously, since the 1960s. Thank goodness things have changed. And then the most recent 2020 view was conducted by the International Liaison Committee of Resuscitation. I'm not going to ask y'all to try to remember the OWL core. It's a lot there. So BLS is a non-invasive emergency life-saving care that is used to treat medical conditions. As you can see, we've talked about airway obstructions. We've gone into the far worst of respiratory arrest and then cardiac arrest, which we know 99% of y'all should have already had the CPR portion. This is just a review of it. So we know cardiac arrest is the worst, and we don't want respiratory arrest. Wow. I'm sorry, y'all. I guess I didn't sleep well last night, or it's just a habit. So we respiratory arrest is the end all. Unfortunately, there's not a lot of return from cardiac arrest. Sometimes you do get lucky and you get a return, but a lot of times we don't, and that's the bad part of our jobs. We'll go over tonight on your focused ABCs, airway obstructions, breathing, respiratory arrest, circulation, cardiac arrest, or severe bleeding, because all of those can be the end of life. And that's something that we need to try to address first, get it handled. Maybe we can move forth from there. If the patient is in cardiac arrest, then a CAB sequence, compressions, airway, or breathing, is used because chest compressions are essential and must be started as quickly as possible. No delayment. We don't want to delay that in any way as possible. We want to make sure that we keep that on the high priority list. Only seconds should pass between the time that you recognize a patient needs basic life support and the start of any type of treatment. Permanent brain damage is possible if the brain is without oxygen with more than 4 to 6 minutes. Now, we think about that and everybody's like, oh, I've seen people hold their breath longer. That's correct. They train their bodies for that. So here's a little clock on how the breakdown is of, so for every 10 seconds, you start losing, for every 10 minutes, you start losing irreversible brain damage you can see on your screen. So that is something that I've always kept in my mind forever, as long as this patient is down. And we know that they've been without oxygen. And if you're looking at 30 minutes, that's 30% of their brain that just won't regrow. So within 0 to 1 minute, you have cardiac irritability. 0 to 4 minutes, brain damage is not likely. 4 to 6 minutes, brain damage is possible. 6 to 10 minutes, brain damage is very likely. And anything greater than 10 minutes, like we said, it's that much more percentage that's off of their the brain possibility returning back to normal. So CPR reestablishes circulation and artificial ventilation in a patient who is not breathing, which we know we've already had CPR. We know that that's our job. We are the beating heart when we start doing CPR, and we're breathing for them, because now this patient is not. If you've never had to do CPR on anybody, it's a traumatic event when you think about it, because you're just like, I don't know, I'm you know, and then when that patient or person passes, you know, I'm sorry, that person passes, it continues to get worse, because you're like, oh, I should have done more. I wish I'd have been able to do this. I wish I would do that. But we can only do so much in this field. We're not the hands of God or whomever is out there that you may believe in, or the healers, the powers to be, but we do our job and we use our skills that we've been taught to do everything we can to continue life on. So we know in CPR, you have your certain steps. You return circulation by performing high quality chest compressions to circulate any blood that's in the body. You want to open the airway. Now we can do a head tilt chin lift. We can do a jaw thrust. So, and then after we've got that, you restore breathing by providing rescue breaths. Now, initially, we're going to administer our 2 rescue breaths, each one over 1 second. And as we're doing those rescue breaths, you want to visualize, we want to look down the heart, look down the chest with our eyes, you know, as we're seeing the rise and fall of each chest each time we give a respiration. So those two rescue breaths will potentially help the patient kick into drive and they start breathing, or it's just one of those, you're like, all right, well, airway's open. Let's start doing. Do we need to do bag to mask? So in most of the time situations, we are going to do bag valve mask. Here's a picture of one. These people, this crew is doing a CPR. It's 2-person CPR. As you can see right here, they have this bag hooked up to supplemental oxygen, which comes to the tube. It's like they're, okay, never mind. It's hooked up right there. And then they have the mask over the mouth right here, and he's breathing for them. They're not simultaneously working on this. This rescuer is doing 30 compressions to 2 breaths. And then after 2 minutes, they rotate. So it allows each person to not get so tired. Sometimes we don't have that ability. If we're in the back of an ambulance and it's just 2 of us, we don't get to trade out. Golly, that's annoying me. I'm sorry, guys, y'all being students. So we don't get that ability to air out. We don't get to, you know, trade out. And so we just have to do the best that we can. Let me send a message real quick. All right. So, and then so again, here, this is the proper way to do CPR. So if you notice the shirt has been removed, they are exposing the chest, the good alignment, the elbows are locked. And this rescuer has the EC grip, because you can see the fingers coming around the mask and at the bottom of the jaw here, which is also holding it down in the front of the face. So I can't really turn my hands like that, but that's how they're doing it. So the EC method is ideal for if you're the rescuer at the top. So BLS differs from an advanced life support. So anytime that you can do so a basic is always going to do basic life support. Intermediate and or a paramedic is the ones that are higher, let me say that, or nurses, doctors are the ones that's going to be able to do ALS. And that involves advanced procedures such as cardiac monitoring. We're going to do IV fluids. We'll use advanced airway adjuncts. So just because you're going to drop a oral airway, or you may be able to put a king airway in, those aren't necessarily advanced airways, because it's the way that king air goes in. It's not necessarily going to be a tube going down into the main stem of the lungs. So that's why it's still a basic life support. So when done correctly, BLS can maintain life for a short period of time until ALS measures can get started. So as long as you start something, the better chances that patient has to continue or potentially move on. So this figure right here illustrates the 6 links in the chain of survival. Y'all have seen that as we go through. If y'all been through CPR, you understand and you know that those links are there. So we talk about recognition and activation of EMS. Then we have immediate high quality CPR. And at the same time, as it doesn't matter who starts the CPR, we just don't want to stop it. You have rapid defibrillation. So in a lot of these places, I've seen them in malls. I know Walmart's got them. They have their own AEDs. My son's baseball team, one of the PT persons that's there, they have, I'm trying to keep my cat off the table. They have an AED that he brings out with him. So then you have your basic and advanced EMS. Now, granted, most ambulance services in the country do basic and a basic and a paramedic. You very rarely will see like a basic and double paramedic or a double paramedic. It just depends. But it's cheaper to do a basic and a paramedic. So then you have your ALS and post-arrest care, to where you do advanced life support measures. And then hopefully you have the last link in the chain is recovery. That's our end all be all goal, is to have some type of recovery. And a CPR, we all aim for is that patient to walk out of the hospital on their own. That's what we aim for, and that's what we hope for. Now, granted, a lot of times that does not happen. I don't have a particular statistics for you on how long people, what's the, people come and go from cardiac, CPR to turnaround and survivability. I don't have that figure, but unfortunately, it's not a lot. So the system components, we talked about that. I'm going to skip that slide. There's no reason for that. Assessing the need for BLS. Always begin by surveying the scene. Is it safe? Is it safe for you? Is it where we can go in there and work without getting damaged? You want to complete a primary assessment as soon as possible in order to evaluate the patient's overall ABCs. Do I need to go to BAC, breathing airway circulation? Because if they gotta be breathing first, so we continue from there. So the first steps to determine the unresponsiveness is a responsive patient does not need CPR. An unresponsive patient may or may not need CPR. And the steps should be not take any longer than about 10 seconds for you to give a quick look at them and be like, okay, they're unconscious and breathing. Okay, well, I don't have to start CPR. So if you look at them and they're unconscious and not breathing, then you need to start CPR immediately. The basic principles of BLS are the same for infants, children's, and adults. We taught that to you, or somebody taught that to you in first in your CPR class. Although cardiac arrest in adults may usually occur before respiratory arrest, the reverse is true in infants. So children will go into respiratory arrest, and then that would be the cause of their cardiac arrest. So that's the only one that will normally change and go back and forth into. So right here, we're showing you demonstrates on how to assess the responsive of a patient. So basically, the only thing I can add to this is when you walk up, take one of your hands and hold their forehead down. Just walk up, lay your hand like this and be like, sir, hey, how you doing? It's Wally from the ambulance service. Can you hear me? And if they can hear me and all that, and they respond, what you're trying to do is you're trying to keep them from jerking their head up forward, and you're laying their hand down on top. So it gives them that ability to not cause any issues when they jerk their neck or anything like that. We don't want that. So the only thing that I can add to this picture is just laying your palmed hand over there. You can do one palmed hand and still rub them on the shoulders or the chest and all that. Pretty much they only need CPR if there's an unconscious and not breathing. That is 100% correct. So the AED, so it's an automated external defibrillator. So the AED is a vital link in this chain because it helps supply the electrical current that's missed in the heart when the heart quits beating. The AED should be applied to the cardiac arrest as soon as it's available. If you witness a cardiac arrest, begin CPR and apply the AED as soon as it arrives. The best thing that you can do, like, make sure the batteries work. First off, a lot of these lay person AEDs, as soon as you unzip the case or take the lid off, they start talking to you. If the batteries are bad, they have an audible chirp that goes on or an audible noise. And most of the time, the companies that have them on a cycle. We have these out on our platform, and we are responsible for checking them every month, which we know the batteries don't go down, but they're a 5-year battery, but we still visually and check them, make sure the pads are still closed. There's a little checklist that we continue to do. AED in children only apply after the 5 cycles of CPR starts. Use a pediatric size pads and the dose when you use a pediatric pad and you plug it to a machine, the adapter that plugs in tells the machine what volts need to be delivered. So if you use an adult pad on a child, they're going to get the adult volts, and we don't want that. You need to make sure that you use pediatric pads for a pediatric patient. You do have special situations. We talk about pacemakers, implanted defibrillators. You want to at least, let's see, what do my notes say? Place electrodes at least 1 inch away from the device. You don't want to put the pad on top of it. Most of the time, your pacemaker or your defibrillator is going to be on the left side of the shoulder some. You're going to have it, it's going to be a little bulge, should stick out about 1/2 inch to 1 inch, maybe 1 3/4 inches. Anytime you have wet patients, please make sure you get them out of the water and you want to dry them off as much as possible. The pad will not stick to them when they're wet, so you want to try to use whatever means possible to dry the area. If the patient's in a small puddle of water or snow, the AED can be used, but the patient's chest should be dried as much as possible. If you know that the patient has any type of transdermal patches, and we talk about a medicine patch, like a nicotine patch, somebody's trying to quit smoking, you need to remove those because they've had studies that show when the AED is delivered and a shock is delivered also, that those transdermal patches can unload all at one time. I don't know how that works. They are not electronic, so I don't know that procedure real well. I'm not saying it's odd, but I just know that that's what they say, and that's one of the things that I do my best to look on the chest, the shoulders, and then anywhere on the back left of the shoulder blades for patches. If you don't see them, maybe they have them on the buttocks. Ladies have the hormone patches on their butts. We just didn't see them. We did everything we could, and it just happens. So positioning the patient for CPR, make sure that the patient is laying supine on their back. They are on a firm, flat surface. You don't ever want to do CPR in the bed. The best thing you can do is get them on the floor, maybe on your backboard or just on the floor in general, because the floors, even with carpet, it's not going to give near as much as the bed's going to give. Ensure that there is enough space around the patient so you're not wedged in between the wall and both of you are trying to work on the same side. At least try to make sure that they're in the middle of the room or to where you and your partner can work around as much as possible. If possible, try to log roll the patient and onto a long backboard, which means if they're flat like this, I want to log roll them up on one side, slide the backboard, and then lay their bodies back down on top of it. That's just easier to kind of help you get ready to move them too. Check for breathing and a pulse, which we know those are sustainable to life. If you don't have either one of those, you're probably not going to live or breathe. These assessments can occur simultaneously and take up to about 10 seconds, and that shouldn't take any longer than that. You want to look for the visual chest rise and fall. Look, listen, and feel if you have to. And then palpate the carotid pulse right here. Make sure you use your 2 fingers and check in. As you can see, they're using 3 fingers. Maybe that's Girl Scout time. I don't know. But make sure you at least use your 2 fingers, not your thumb, because you know your thumb has a pulse in it. Provide external chest compressions. That's our job. That's what we called there for. They called us to this birthday party, not for cake. It's because grandma just died. And now we got to do our best to get grandma back. You want to apply a rhythmic pressure and relaxation to the lower half of the sternum. Compressions squeeze the heart and acting as a pump to circulate the blood. And avoid leaning on the chest in between compressions. Yes, you're going to be tired. You're going to be worn out. But at the same time, is do your best to make sure you look professional. Don't be looking slouchy. And I know we're tired. We may be the only responders. There may not be any other first responders, but sometimes you'll have fire that shows up or fire beats you there. And they've already started, and we need to share the love and make sure we dive off into their CPR rotation too. I know I Staying Alive is the best song that you can do. Just don't play that song, or Another One Bites the Dust. Those have the same rhythmic the songs to doing your chest compressions on a right normal basis. Proper hand position. In your book, it shows you on 14.1. I like to remind ladies, don't wear your ring on the bottom side. If you have to, you know you're going to a CPR call, take your ring off, put it in your pocket, secure it somewhere. But sometimes I've seen when they do CPR and their hands get reversed and their rings are facing down and they push, that's they can cause damage. And Mario, we don't want to play those songs out loud, nor do we want to try to sing those two songs. There could be some offense taken there. So here's a figure on this illustrates that the heart lies just left of the middle of the chest. So what we want to do is put our hands on the anatomically correct position for the nipples should be straight across the center part of the chest. Here's our midline right here. We know that. So we should go about quarter line down the midline and then left and right. That's where they say the anatomically should be, because that's where the nipples should be on the normal person. So here's what it looks like when the chest is compressed. You can see that it's down to about a 1-to-1 ratio. And you can see this is where there's pressure coming off. So there's pressure returning to the heart here. This care provider is pushing down on the sternum, and it's actually pushing heart through heart. It is compressing the heart, but it's actually compressing blood, pushing blood throughout the rest of the body. And you notice also they're on a firm surface. You can see that there's nothing underneath them. It is pretty cool view that you can see right here. So, you know, the lungs, the sternum, there's your spinal cord. Not real sure what that is. I'm gonna say that's the intestines. We're gonna go with that. And we're just gonna change slides. So head tilt, chin lift, we should know about that. We've talked about that, so I'm not gonna harp on that long. Just remember, if it's a head tilt, chin lift, there is no suspected spinal injury. If there is suspected spinal injury, we just do the jaw thrust. If the patient is breathing and they're adequate and they're on their him or her own, we don't have to do anything. And it has no signs of injury. Maybe they did fall asleep. Maybe they're intoxicated. Maybe they did have a medical condition, but they are breathing along. We don't see any particular injuries. We're going to put them in the recovery position. Here's the recovery position. It is on the left-hand side. I always thought when I was coming into this that we put them on their left-hand side because in the ambulance, I can see them face to face. Well, it's not really true, but that's what I thought. So when we do this, make sure that the leg, the right leg is shortened and extended like this, and their left arm is straight and their right arm is underneath the head. So what this is doing is preventing them from falling over on their face, and it's preventing them from rolling over. So if they do vomit right here, it's not gonna, it doesn't create a respiratory issue. And we're trying to keep them with this leg being over. So we're trying to keep them from rolling back. So where if they do vomit, they can swallow their own vomit and then we'll have an issue there. So that's one of the things that's in the recovery position that's super helpful, that it helps prevent both of those rolling over on the face and rolling on the back, because neither one of those are good when they're in a unconscious position. A lack of oxygen, which creates them to be hypoxic, and combined with too much carbon dioxide in the blood, which is hypercarbia, is lethal, which we know we've seen people that try to commit suicide by locking themselves in their car or in a garage with some type of delivery device of the exhaust being brought in to the air and to the car. So you can have hypercarbia and then hypoxia. Those two are both fatal. Let's see, provide slow, deliberate ventilations to last at least 1 second. If a patient is not breathing, such as, and ventilations are be given by a 2-person EMS provider or 2 EMS providers, you want to use a barrier, pocket mask, one-way valve, a bag mask device. Wow. And here is, they are using the BVM. So let me point this out. So you have the mask right is here. You see that they have the EC clamp. So these fingers and the index, thumb and the index is making a C. And then you have your index, middle, and ring finger that should be down here on the bottom side that is making the E. So that's holding that in place. You can also rotate the head back so you can do a head tilt chin lift. And this particular one, the left hand, is doing they're ventilating the patient because you can see the bag is squeezed. So remember we talked to this the other night. So this is also a size 10 millimeter right here, that these two pieces can be separated. And this right here will automatically fit over the ET tube. So once the paramedic or advanced has gotten there and they drop a advanced airway, you don't have to worry about tracking something else down. These two pieces, you can see that line fine right there, can be separated and that be put on top of the ET tube. And now you have to change nothing. Remember slow ventilations. We don't want to hyperventilate the patient. It's still not going to do anything better for them if we hyperventilate them. So with patients that have a stoma, the little hole in the neck, you can use a bag valve mask for them. And we talked about this the other day. There is a picture of a stoma. This is actually a cadaver. You can see the eyes are closed in this picture. So you know that's a cadaver. So there's what a stoma is. And you see down here, they are using an infant mask, bag valve mask. They're using the mask off of the bag valve mask for an infant hooked up to an adult bag. So it's just another way that we can deliver oxygen through here. Those are our oxygen delivery systems there. So we can still deliver it until now. We still can intubate through here, and you can actually have a visual confirmation that you see it, but that's not down my lane. That's cool. Hold on 1 second. All right, one rescue adult CPR. So you still know that if you're doing this, you're going to be doing a 30 to 2. I have no idea. I'm doing 32, and it's going to be on you. You're going to be doing 30 compressions to 2 ventilations, and then back to back to back. Now, it is, again, we talk about doing 2 rescuers. You try to rotate out every 2 minutes. So if you do 2 cycles of chest compressions, you do 2 cycles of ventilations, and then you continue to cycle out. If you have more and more people that shows up, means you really only got to do like 1 cycle. And I like people to show up and help me. So a 2 rescuer adult CPR, this is always the preferable method. Trust me, because it's nice to have help. The rescuer who's doing the compressions can be switched, which is what we talked about. Switching rescuers depends on, we don't want to compromise any of the CPR. We want to limit that. My hand's fuzzy, so we want to limit the interruption of doing high quality CPR to a minimum. We don't want it to create any type of issue. So a good thing is like you do it as fast as you can. You create a rhythm so that it's not interrupted. So devices and techniques on doing CPR deliveries. So you have your active compressions, which is a false pressure chest. That's active. All right. So you have your regular CPR, and many increase the amount of blood that returns. So the machines that do CPR for you, you have one of them is called an ITD, as you see right there, independent downward threshold device. Here is another type of device. I have very good familiarization with a Lucas device. The Lucas device looks something similar to this. So it is basically the same thing. This is a auto CPR, or it's an auto pulse by Zoll. I haven't really used one, so I can't really talk good things or bad things about them. But the best thing about it is it does CPR for you and you don't get worn out. They are mini boards, as you can see here. You want to log roll the patient over, make sure the strap is tucked underneath them or laid off to the side. So that way, when you roll them back over there, you have the ability to attach this band. It has to be attached. You can kind of blurrily see this picture. You want the arms of the patient to be laid out to the side. and the band comes underneath the chest. The Zoll version, the Life Pack model, sits right over the center of the chest. You can adjust it a little bit, may have to move the patient up or down, and it clamps on. They work very familiar to the same thing. So you have a mechanical piston device, you have a load distribution band. They're both of those are operated off of that. The Life Pack one is a mechanical piston that is operated off a battery, and then the Zoll that you just saw, the load distribution band. So they do the chest compressions, and it's the same rate, same everything. It's a pre-program. We don't have to do nothing besides to get it on them, and it's amazing. Does it for you. The only thing you have to be super careful of on both of these devices is that when you move the patient, you just have to make sure that it's still in the same spot. So this would go on, then you would put them on a backboard. You want to make sure that anytime that you move the patient, go back and check placements of anything, because they can move a little bit, and it may be in a bad spot, or it may be over another particular wound that you want to try your best to move off of. Cardiac arrest in infants, most of the time followed from a respiratory arrest, which turns and leads, it triggers their hypoxia and ischemia, and then now the heart is ischemic and they go into cardiac arrest because they ain't got no oxygen. That's majority of the time when infants go into cardiac arrest. Some other particular issues is causes of respiratory problems leading up to cardiopulmonary arrest in children. You have your injury, could be blunt or penetrating. Infections of the respiratory tract or other organ systems, which creates shock. A foreign body in the airway, which is a quarter, everything that goes in their mouth as kids. You can have submersion. You can have a dry drowning or a wet drowning. Electrocution, poison or drug overdose, which could be found by taking a parent's drug, something found underneath the cabinet and they put it in their mouth. Or you can go into SIDS, which is the sudden infant death syndrome. Those are all traumatic. All 7 of those are super traumatic to the individual, the care provider, the family, the parents. It's one of those that I hate working pediatric deaths. I hate working children deaths. It's a little bit easier when you go into adults and to geriatrics, but it's still traumatic when you start to talk about any type of child. Let's see here, determining responsiveness. So on children, you want to gently tap the shoulders and speak loudly. If you find an unresponsive apneic pulseless child when alone or off duty here, begin performing 5 cycles of CPR. It's about 2 minutes worth, and then go call EMS. You want to check for the breathing and the pulse. Palpate the brachial artery in infants, which is the arm. The infant or child must be lying on a hard surface, which we know we already talked about that because that's the best place to do CPR. You only use your 2 fingers when doing an infant's chest. If there's 2 rescuers are performing CPR on an infant, use the 2 thumb where we wrap our hands around the back, and we're using our thumbs, we're compressing like this. And children, especially those older than 8, you can use the heel of one hand if you need to. I've actually done that on some elderly patients too, or smaller adults that my hand covers the majority of their chest. I will do a 1-hand compression. If you'll look in your book on drill 14.4 and 14.5, it talks about performing infant chest compressions and CPR in children between the age of 1 year and the onset of puberty. Kind of shows you the proper placements and how to do it in the better positions. Anybody got any questions so far? I'm just trying to, I know I'm talking fast, but it's a recap on CPR, and everybody should know your CPR. You've already had it, and you passed it, and you got to here. It's just a refresher. Any questions? Let me stop, go back over anything, or you see me keep going? All right. We have 46 slides more. I mean, no, yeah, 26 more slides to go. So I didn't figure I'd give y'all a break if that's okay with y'all. So I didn't talk about that one. All right, foreign body obstructions in children. That is very common. We know that kids put everything that goes to their mouth. They just don't know. They don't know no better. So place an unresponsive breathing child in the recovery position. The two common techniques to maneuver open an airway are modified to the pediatric patient. You can place a wedge or padding underneath the child's upper chest and shoulders to avoid a partially obstruction of airway. So you kind of want them shoulders back, head down like this. So what it's doing is it's opening that airway for them. And you're anytime that you put somebody on a backboard, you want to pad the voids. And what I mean by voids is open space. So here's my board, and if I lay down and I have a void like this underneath the head, I want to place some padding right here underneath my hand to where I can make that void null and void. So I'm taking the pressure off of those muscles. Providing rescue breaths. We know that anything that's not breathing and has a pulse, you give them 1 breath every 2 to 3 seconds. If they're not breathing and no pulse, they do 2 breaths for every 30 compressions. That's back to the 32. You want to allow the child to stay in whatever position is most comfortable if you give them back. In a child with a tracheostomy tube, which is a trach tube, remove the mask of the bag valve mask and then connect it directly to the tracheostomy tube to ventilate that child, because it's a direct path. So let's use it. A face mask with a one-way valve or barrier on the tracheostomy can still be used. But if it's there, it's just like that child being intubated. And I'm sure going to use it when I walk in the door and be like, oh, look, somebody already did my job for me. And I'm happy. Anytime you try to interrupt CPR, we want to keep that as a very minimum ability. Interruptions at all need to be kept to a little. CPR is a crucial life-saving procedure that provides minimal circulation and ventilation until the patient can receive defibrillation. No matter how well the performed CPR is rarely enough to save a individual's life. If ALS is not available at the scene, provide transport based on your local protocols. Remember that, and continue CPR on the way in. Consider requesting ALS to meet you. You may be able to do an air transport. Maybe they can pre-land at a baseball field or a football field, and you meet them halfway there, and that would be helping getting ALS there faster for you as a provider, and for the patient's betterment of an outcome. Try not to. I already talked about that. I'm not going there. All right. So when do we not do CPR? We've been harping on doing CPR. So when do we not do it? So if the scene is unsafe, I'm not going in to start CPR, because now it's going to be potential life endangerment for myself. If the patient has obvious signs of death, which include the absence of a pulse and breathing, along with any one of the following findings right there. So rigor mortis, that is the stiffening of the body after death, which means they've been dead for at least 3 hours. Dependent lividity or liver mortis, I have a picture for that. Where they start to become like the decompensation. It's gonna tell y'all. And then evidence of a non-survivable injury, decapitation. Obviously, if like the heart's missing out of there, there's open cavity, loss of mass of blood. So this is dependent of lividity. As you can see here, this is actually a hand that may have pushed to roll them onto their side, and it pushed deep into the tissue. The blood pools into the lowest part of the body wherever they're laid. So if you happen to see that, you're not doing nothing. You're not bringing them back, folks. I'm sorry to say, it's just not happening. If the patient and a physician have previously agreed to do not do a DNR, you can look at the paperwork, make sure it's up to date, make sure it's good to go, and you don't have to do anything. Now, check on when you get to there, look at these DNRs. The more you see them, the better off you'll be when it's time for them to be in a position to where you have to make that call. Because if if your area, your region, your local state procedures and protocols require these to be updated every 90 days, if they're not updated every 90 days, you may not have to follow them, and you may have to do CPR on this particular patient. Now, I've had this happen too. If you have a DNR and the family has agreed to it, but for some reason it was traumatic for their father, mother, grandmother to pass, and now there's one person out of this family that does not agree with that DNR and they want everything done. Well, so then you have to provide CPR only while you contact med control to try to get some clarification to this if you can't work it out. So those are some instances I just wanted to let y'all know and be aware of. So when do you stop CPR? So the stop method that's on your screen right there helps out a lot. And so patient starts breathing and has a pulse. T, patient is transferred to another provider of equal or higher level of training. O, you were just wore the hell out. You can't do it and you're the only one there. Or P, a physician directs you to discontinue. I have worked a call before where I've done full ALS procedures. I've intubated, I've IV'd, I've put drugs in, I've continued things for about 30, 45 minutes. I had some changes, they went away, didn't get anything for a long time, delivered shots, got something back. And it was just, I had to stay where I was because I can't do this on my own. And I actually had people on scene that were helping me. So I stepped off and I spoke to the family, and I called med control and told them that there had been no life sustainable change in the last 15 minutes. And the patient has been down for about 45 minutes. And the physician says, okay, you can stop at this time. You don't have to continue to do anymore. As soon as he said that, I said, okay, doc, remind me again how to spell your last name. And at 1941, we're calling this as deceased. And they spell their last name and they say, yes, that's correct. So you can still get that assistance that you need from med control the same way when you need that physician. So I want to add in a keynote to the O. Just because you're out of strength does not mean that you're just tired, but it means you're physically unable to continue. So if you're just like, man, I'm wore out, I can't do it no more. That's neglect, and you just potentially killed this patient. So what we want to do is we want to continue CPR until we physically can't go no more. All right, that didn't change. So foreign body in the airway, we can know that can be caused by relaxation of the throat muscles in an unresponsive patient. They could be vomited or regurgitated stomach contents. Make sure you got suction handy. You got blood, damaged tissues or after an injury. Dentures will kind of get in the way too. And foreign bodies such as food or small objects. Recognizing that there is a foreign body obstruction is key because we get to get that early and we're able to pick those things up. In adults, foreign body airway obstruction usually occurs during the mealtime. It's always meat, some type of meat. In children, airway obstruction usually occurs during a meal or at play because they take big bites and they try to swallow it all at one time and it just gets lodged. And mid-airway obstructions, which is a patient is able to exchange adequate amounts of air, but still has signs of a respiratory distress. Leave these patients alone, observe for signs of severe airway obstructions, and transport them to the hospital. If you've tried the Heimlich maneuver and it didn't work, okay, just get in the truck and let's go. Be prepared to do any type of life-saving procedures while you're on the way to the hospital, but you ain't got to do nothing because they're still breathing on their own. They just have an airway obstruction. So in responsive patients, a sudden severe obstruction is usually easy to recognize in a responsive patient because they can tell you that something's going on. The person is suddenly unable to speak, cough, or grasp his or her throat, and it turns a cyanotic blue color and makes very unsuccessful efforts to breathe. You may hear a stridor respiratory rate pattern at that time. Unresponsive patients, and an unresponsive patient suspect obstruction if a maneuver to open the airway and ventilate are ineffective. So if you go to bag them and that bag's super hard to compress, something's blocking it. All right, during a foreign body airway obstruction in an adult, abdominal thrust, the best that you can, that's the Heimlich maneuver. It is recommended in a responsive adult and child that is 1 year and older. So you create an artificial cough. If the patient with a severe airway obstruction is unresponsive, then perform chest compressions. Same thing. Here's a picture of it being done. Obviously, she's awake, alert, and oriented. And first thing I noticed is, look at that jugular vein, man. I could put a big old needle on that EJ tube. On the EJ, man, I could poop right there and we'll be good to go. Sorry, side note right there. Instead of doing abdominal thrust, use the chest thrust to use these in responsive patients. Women with advanced stages of pregnancies or obese patients, we just not gonna be able to fit our arms around there. And we may injure the child, or just if they're obese, it ain't working. So we can do something like this. We'll be able to go on, for this particular lady, we can go on the top side of her breast and still do this. So what we're trying to do, we're only getting the top portions of the lung, even though we like to go lower so we can get the, the full capacity of the lungs. But we know at this point in time, it's just not possible. And we're gonna do the best that we can. It is what it is. We're gonna do something. In responsive patients who become suddenly unresponsive, we just don't want to be like, whoops, we're done. All right, well, he's on the floor now. Be very cautious. You want to lower these patients to the ground, and if you are helped, then help them. If you're not helped, send somebody to call help to get them there. You want to perform about 30 chest compressions. Do not check for a pulse before beginning chest compressions because we know they went unresponsive for something. Open the airway and look in the mouth. If you see an object that can easily be removed, remove it with your, see, I don't like when they say remove it with your fingers because that's not cool. You don't need to stick your fingers in there. We have these long tweezers, basically. It's got a McGill forceps is what they are. And they're scissors types with the handle. You stick your fingers in there and they curve. So that's better. So that's, yeah, it's not cool. Let me see what you said. Regarding a good bolus in adults, do you give glucagon and while they're in routes? I'm not understanding your question there. If you can give me some more information, maybe I can help you out. I'll wait if y'all can read the question. I'll answer it when it comes back up. How about that? All right. Even though glucagon is used to treat blood sugar, it can also relax the smooth throat muscles to help. Correct. I've never done that. Let me just say it that way. That's a good question. I haven't seen that in several of the agencies I've worked for. That's never in one of their procedures or protocols. So I would say not. I mean, it's good question, but I would say no. That's the best answer I can give you just for a little bit of knowledge. Sorry, but I can try to find you an answer, get you a better answer than that. So let me phone a friend here, see if I can send you a message later on. When we talk about foreign body obstructions in infants, airway obstructions is a very common problem in infants and children. A patient who has signs and symptoms of airway obstruction, do not waste time to dislodge the foreign body. Administer supplemental oxygen if needed, and immediately transport the child to the ED. As long as the patient can breathe, cough, or talk, do not interfere with his or her attempts to expel the foreign bodies. Let them do that on their own. Administer supplemental oxygen if needed and tolerate it, and provide transportation to the ED again, which is where we're going. We know. On responsive standing or sitting children, perform the Heimlich maneuver, but with less force than it would be done on an adult. Unresponsive child less than 1 year who has airway obstruction is managed in the same maneuver as an adult. Bam, look, there's a picture, 14-31. So let's look at this one. So what we see here is the child standing, but the care provider is at the same height of this child. So that's important because we don't want to grab them and stand them up, because we're pulling against them to keep them at our height. And then they're at our height instead of standing on their own feet. Well, if they go unresponsive or we lose grip, now we just drop this child, and that's not going to be good if we cause injury. So if you come across this, do as this care provider here is doing and get down to their level. That child is trying not to smile, but follow directions, probably from their mother. But we want to make sure we do it at their level. That's the most important part. Responsive infants, we do want to do abdominal backs. We want to perform back slaps and chest thrusts, which are considered compressions. So that is, that baby's not happy. I'm gonna say it's, I'm gonna go with a boy because it's in blue, but they not happy at all. So if you notice on the figure A, what they're doing is their hand is open, the child's head is laying right here between the thumb and the C. I'm making a C and I'm holding it, and the other fingers is underneath the throat. So I'm holding it position. I like to hold it in my weak arm, have their legs go on either side of my arm, which means I have control of them like a football, and I can protect them. I can flip them over and do chest compressions this way. I can flip them back over and do back blows. That's just the way that I like to hold them. The only thing I would do different here is I would put this foot on the inside of the body and this foot on the outside. So when I go to flop them to my left arm here, one foot stays against the body and one foot goes out automatically. It's easier for me to handle them. You do what's best for you, but again, that's the way that we want to do it. And in unresponsive infants, don't check for a pulse, but do begin chest compressions. Open the airway and look in the mouth, because we know infants have most common are the airway obstruction, which creates the cardiac arrest. If you see an object and a child or an infant, I would probably stick my finger in there and try to remove it. If you do not see the object, resume chest compressions. Continue the sequence of chest compressions, open the airway, look inside the mouth until the obstruction has been relieved or a ALS care provider arrives. Then it's like, okay, here you go. You can take it from me. Thanks, holla, we'll see you later. No, we're gonna stay and help them. On an opioid overdose. So we're gonna give them Narcan. Remember, depending on the size of this person, do we want to give them the full dose, or can we want to try to give half dose? Know your dosages that are on your ambulance. Majority of the times that we have are 4 milligrams. So be cautious of that. So priorities when we find somebody that is suffering an opioid overdose is we want to perform high quality CPR to relieve the pressure off the aorta or the aorta and vena cava. If the patient is pregnant and is not in cardiac arrest, then position her on her side to relieve the pressure on the great vessels. If she is in cardiac arrest and the top of the patient's uterus can be felt at or above the level of the umbilicus, perform manual displacement of the uterus to put the patients to relieve the aorta clavicle compressions while performing CPR. Sorry. So basically what we want to do is try to feel for the pelvic area. We need them to sit low so we do proper CPR on that part. Most of the times you can still, even if the woman's carrying high, we can still do good CPR. I'm not going to be manually moving anything, so be cautious of that. And we want to make sure when we do CPR on a pregnant female that we're doing very adequate, very predominant good CPR, because now we're working on with two, not just one. So once a loved one has passed, it is also our job to provide grief support. It's okay for EMS in this position to get emotional. It's okay for us to be attached. Be very concise and clear on what's going on. Try to get one of the EMS providers or one of the fire department guys to be the contact. Let them go to that one person so they can gain the trust and get inside there. But be very, very, just keep them well communicated. Let them know what's going on. You want to keep them informed of the processes, how things are fixing to work, what's going on now that Fred has passed. And we want to give, if a lot of people ask, I want to see them. I'm not a big fan of letting the family see them on scene or anything like that, because you want to remember them in their last best incident. Well, we're not seeing them in their best incidents, especially if it's a traumatic issue or anything like that, and specifically if they've got tubes or wires all in them and all that. We don't want them to see that. A lot of times it is a grieving process for mothers and fathers to hold their little loved ones. I know at the hospitals they work very careful when they do that. So if you've never done that, ask. What do we do? I don't know. I need to help this family. I don't know what to do. After recession takes place, has been stopped. Some other measures that can be helpful. If you're in the family home, try to get them all to sit in one particular area. Again, go back over of introduction of who you are, and does anyone want to talk to me privately? Can we talk? But I want to let everybody know at one time. You want to be very clear, and your English needs to be very, you don't want to use any abbreviations or slangs or anything like that. Be very sensitive to the family. Instead of saying, well, he was a good old feller, try to use their first or last name, Mr. or Mrs. Use eye contact to whomever you speak with, and be what somebody talking to you would want to be. Be that person that has that interest, that love, that care, that want to be very helpful, because this is a traumatic situation. Expect family members to show emotion as they begin to grieving process. There potentially can be some violence. There can be potentially some loud four-letter words and some other syllables added in there. Ask the friend or family if there's somebody that you can help call, or would you like one of the local pastors to be called? I'm living in a Bible Belt area, and that's it's one of the big things we used to help do a lot when I was at the fire department. Is we kind of got to know the clergies and pastors of the area, and we knew who to call. When you need to leave, turn to the family over to someone else, maybe law enforcement, introduce them. Ensure that children are not ignored. Let the children ask those questions. They sometimes ask some of the wildest ones, so be ready to answer those, because you're like, yeah, and you look around and everybody's looking at you to answer, and you're like, yeah, I don't, oh, my phone's ringing, so be prepared for that. CPR skills can deteriorate over time. That's like, if you don't use it, you lose it. That's my motto, because I try to stay in remembrance of that, because I don't do a lot of cardiac calls anymore. We don't get too many offshore that I get to look at their heart rhythm. So I try to stay up on my cardiac things. I'm teaching CPR at least, if not every hitch, it's every other hitch. So I stay up on my CPR procedures. And that's the reason why we require y'all to go back through CPR every 2 years, because something has changed or something's modified. If something drastic is changing in the area, your company and our agency will bring you back in through a continuing education class. They may send out an email saying you have to watch this, sign this piece of paper saying you're aware. But all that's doing is allowing them to say, hey, you've been educated in this process and you should understand what's going on. But CPR is always going to have to be renewed every 2 years. Education and training. I obviously like education and I like doing training. So being the ability to be a CPR instructor, because ARES, we teach through all the country, and having the ability to be a CPR instructor is really cool. And you help train the others. You can do first aid, CPR, and AED training. As y'all know, you can get that from anywhere nowadays, but make sure it's the particular ones that you need, like American Heart Association is the one that you need going forth in your careers, because that's the one that's recognized by National Registry. That's it, y'all. Maybe I lied. I kept it to an hour. I know y'all happy. Does anybody have any questions about tonight? It should be a refresher, should be a reminder from your CPR class, so it's not like it was a whole lot. I do want to add, I'm going to stop this. Oh, hang on. Let me pause this share for just a second. Let me see here. So this particular module is super duper big. So we start with 13, and your next module test is not until after chapter 23. So you have 10 chapters in this module. So remember that you guys only get one retake a module. So be very, very careful on how y'all do that. Because if you happen to use yours in an early standpoint, you're not going to be able to use it later down the road. And remember, your mod exams, you get 4 days. Your regular chapter test, you get 3 days. As y'all have noticed in your grades as we going through here, after the time has expired, I do place that with a 0. So your grades are very fluid and active, and you know what your grades are. The ones have communicated me, and I know there's been issues in there. Yes, I will go back in there and fix that. We will make sure that you get to retake your particular chapter. So y'all don't worry about that. Y'all are a one-on-one basis. But the ones that's been here from the get-go and kind of have everything going, please be smart about your test. Make sure that you set these reminders, because we got 10 chapters to go through before y'all take a mod exam. And it's going to be hard, I'm telling y'all right now, and we're not even down the road in it. So please understand that. If you need some help, ask in the Discord group that you need some help, and we can answer you. We can get you some answers the best that we can. Maybe it's something that we need to do a one-on-one with you, and we can help you understand a little bit better. Please don't be scared to reach out to any of us. Remember, it's the weekend. It's busy for me this weekend, so I will be able to answer through to Discord to tomorrow, and after that, I will not be able to reach again until Monday. Like I said, it's busy, and my other business is rocking and rolling, so I stay pretty busy with that too. Guys, gals, do y'all have any questions for me about CPR tonight? I guess silence is a key. All right, so there's your code for tonight. That is your class code, 0 $XTY. That is your class code for tonight. If y'all need anything, reach out. Y'all have a wonderful night. Good weekend to y'all. Please do not forget to take your test. Y'all have a great night. We'll see y'all in the next class.